Welcome back to the Deep Dive. Today, we are going to put ourselves right in the middle of a storm. I want you to just picture this. The doors of an emergency room, they just burst open. You're in that critical window, they call the golden hour, right after a huge accident.
Right.
You have a patient, maybe they've been pulled from a car wreck or they've fallen from a high place, a construction site.
It's just noise and chaos everywhere.
Everywhere. Monitors are beeping, people are shouting, and in all of that, you have to make these life or death decisions.
Yeah.
In seconds.
Yeah, and it's a terrifying scenario. I mean, even for people who've been doing this for decades.
I can't even imagine.
And the scariest part of that whole scene, it isn't always the stuff you can see. You know, the broken leg bent at a weird angle or the cuts. The really scary part is what you can't see.
And that's what we're getting into today.
Exactly. Today we're doing a deep dive into the clinical management of something called blunt abdominal trauma. Doctors, they usually just shorten it to B.
BAT. It sounds blunt. And looking at this stack of research you brought in, this is a heavy one.
It is heavy, but it's also surprisingly logical. We're dealing with what I always call a closed box mystery. That's really the theme of the source material we're looking at.
A closed box mystery. I like that.
You've got the human torso, that's the box, and it has been shaken violently. Something inside is probably broken, maybe torn, definitely bleeding, but, and this is the key, unlike a stab wound or something, there's no hole to look through.
You're flying completely blind.
Completely. And the cruel twist in all of this is that you can't just rip the box open to see what's wrong, because opening it up, that very act could be the thing that kills them.
And that's the tension, right? That's what we're going to explore. We have this huge pile of clinical guidelines, stuff used for really high-level medical exams, the USMLE, trauma board.
The serious stuff. These are the battle-tested algorithms that surgeons use to bring some kind of order to that chaos.
So our mission today is to really pull out the logic behind it all. And this isn't just for doctors. It's like a master class in prioritization, how you think clearly when everything is falling apart.
And how to avoid the cognitive traps, the little mental shortcuts that could cost a life.
Exactly.
And the logic we're going to unpack today. I mean, how to triage, how to ignore the loudest problem to focus on the quietest killer. It's honestly applicable to critical thinking in almost any field.
But here the stakes are. Literal.
Literal survival, yeah. And just to ground this for everyone listening, the #1 cause of this kind of trauma, road traffic accidents.
Yeah.
RTAs, this isn't some rare thing. It's an everyday reality in ERs everywhere.
Okay, so let's walk through those ER doors. We have a patient, car crash. They're awake, but they are in agony, clutching their stomach. I mean, my instinct, anyone's instinct, is to look at the stomach. You want to ask, where does it hurt? You want to see the bruise.
Of course.
But the source material, it just throws up this giant red flag right at the start. It calls this the exam trap.
It is the single biggest trap for a novice, for sure, but even for experienced people who get, flustered. It's like a moth to a flame.
Right.
The patient is screaming about their belly. Maybe you see a big seatbelt bruise.
Right.
Your eyes, your brain, your empathy, everything is just screaming, fix the belly, that's the problem. But the algorithm, the protocol that trauma surgeons live and die by says, stop. Do not look at the abdomen.
Not yet. That takes an incredible amount of discipline. So just ignore the thing that's screaming at you. It almost feels wrong.
It feels wrong, but it's actually the highest form of care.
Yeah.
You have to ignore it because of, the hierarchy of death, a ruptured spleen, a bleeding liver. As bad as that is, it'll probably take an hour, maybe 2, to kill you.
Okay.
A blocked airway, a collapsed lung. That'll kill you in 3 minutes. You can't fix a ruptured spleen if the patient suffocates while you're poking their belly button.
That puts it in very stark perspective. And this brings us to the absolute foundation of all trauma care, the primary survey.
Yeah.
A, B, C, D, E.
The bedrock.
And I want to go through these because the sources are so clear. The order is non-negotiable. You can't just freelance this.
Absolutely non-negotiable. You skip a step, people die. It's that simple. We start with A. A is for airway. But in trauma, it's not just is the patient breathing. The full name is airway with cervical spine protection.
Okay, let's drill down on that. C, spine protection. Why is the neck so tightly linked to the airway here?
Just think about the physics of a car crash. If a force was strong enough to, say, break a femur or rupture an organ inside the belly,
It was definitely strong enough to snap the neck.
for sure. The cervical spine is so fragile. And if you have an unstable fracture in there, a little piece of bone sitting right next to the spinal cord, and you do the standard CPR move, the head tilt, chin lift.
Yeah, the one everyone learns.
Exactly. If you do that, you could just shift that bone fragment right into the spinal cord.
That's it. You've paralyzed them.
Or killed them, depending on how high up the injury is. So the rule is you just assume the neck is broken until you can prove it's not.
So how do you open the airway?
You have to use a specific maneuver called the jaw thrust. You're basically pulling the jaw forward without moving the head at all. Often someone else is literally holding the head still. We call it inline stabilization.
Okay, so A is secure, the neck is stable, air can get in. Then we go to B, breathing. Now, to me, airway and breathing, they sound like the same thing.
In this context, totally different. The airway is the pipe. B for breathing is the pump and the gas exchange. You can have a perfectly open pipe, but if the chest wall is crushed and the lungs can't actually inflate,
The hair's not going anywhere.
it's not doing any good. So we're looking for chest rise, listening for breath sounds on both sides, making sure oxygen is actually getting from the lungs into the blood.
So only when the pipe is open and the pump is working do we get to see circulation. This is where we finally start thinking about blood, right?
Yes, but specifically hemorrhage control. We're not doing a detailed heart exam here. We are checking for a pulse. Is it fast and weak? Is their skin cold and clammy? We're looking for big external bleeding that we can put pressure on.
So it's our first clue about the abdomen, but we're still not actually examining it.
Exactly. We're just checking the global state of the system. Is the tank full and is the pump working?
Then D for disability.
A quick neuro check. Are they awake? Are they confused? Do their pupils react to light? It just gives us a baseline for a potential brain injury, which is really common with this kind of trauma.
And finally, E, exposure.
Which means we cut off all their clothes, everything you have to. You can't find a small puncture wound through a pair of jeans. You have to see the whole patient front and back.
Front and back, so you have to turn them over.
Yeah, we log row them. The whole team turns them as a single unit to keep the spine straight, and we check their back. And then, this is critical, we cover them right back up with warm blankets to stop them from getting hypothermic.
It's just a brutal efficiency. Strip, check, cover. Now, the sources have this warning that I found really powerful. It says, never jump to abdominal CT before completing ABC.
That is the golden rule. Written in blood, really. And I've seen it happen. A junior doctor, they see the big swollen belly, the patient's in pain, and they rush them to the CT scanner to see the liver.
They want the map. They just want to know what's broken.
They want the answer. But the CT scanner is a lonely place. We sometimes call it the donut of truth, but for an unstable patient, it's the tunnel of death.
The tunnel of death. Wow.
Because once they're in that machine, you can't get to their airway easily. You can't do good CPR. If they crash while you're taking these beautiful pictures of their spleen, you lose minutes just getting them out, minutes they don't have.
That is a really chilling image. It highlights the difference between diagnosing and resuscitating.
Perfectly said. The goal isn't to know what's wrong right away. The goal is to keep them alive long enough for you to find out. Diagnosis is a luxury for the stable.
Resuscitation is the mandate for the dying.
You got it. You treat the physiology first.
Okay, so we've been disciplined, we've done our ABCs, the airway is good, breathing is okay, we're managing circulation. Now we can finally turn to the abdomen. We're ready to look inside that closed box.
Now we get to play detective. And the first step isn't touching them. It's asking questions. We need the history, specifically the mechanism of injury.
Context is everything.
It tells you the physics of what happened. Was it a high-speed crash? Was the patient ejected? That means huge deceleration forces, organs slamming into bone.
Or like a bike accident.
Yeah, a handlebar injury from a bike. That's a very focused, direct impact. It's almost like being speared in the gut. Or a fall. Falling from standing height is one thing. Falling from a 3-story building?
A whole different ball game.
Totally. The story primes you for what to look for.
Okay, so you have the story. Now you look. What are the red flags? How do we know something's wrong inside without opening it up?
Well, pain, obviously. But we look for specific signs. One is distension. Is the belly swelling up? That means it's filling with something, usually blood. And there's something called guarding.
Guarding, like they're physically blocking your hand.
It can be that, but it's also an involuntary reflex. When you have inflammation inside, the abdominal muscles just spasm. They get rigid, like they're trying to whore a shield. If you touch the belly and it feels like a wooden board,
That's bad.
that's a surgical emergency. That is the body literally screaming, I am dying inside.
But the number one sign, the one the source material puts in bold, is shock. And the mantra is, shock in blunt trauma is hemorrhagic until proven otherwise.
Let's unpack that word shock because people use it all the time. I was shocked. In medicine, shock means your organs aren't getting enough blood. In trauma, it's almost always hypovolemic shock, low volume. The tank is leaking.
And the body tries to compensate.
Right. You lose blood, so your blood pressure starts to drop. That's hypotension. To make up for it, your heart starts pumping way faster. Tachycardia. And because your brain isn't getting enough fuel, you get confused, agitated, altered sensorium.
So low blood pressure, racing heart, confusion. If you see those three, you just assume they're bleeding out somewhere inside.
Yes, and you assume that blood is in the belly or the pelvis until you can prove it's not. You don't just say, oh, they're anxious. You assume they're bleeding.
Okay, but here's where it gets really tricky. The physical exam trap. We said a rigid belly is bad, but the source also says a soft abdomen does not exclude serious injury. That just feels unfair. You check them, they feel fine, but they could still be dying.
It's the most treacherous part of the whole thing. You palpate the stomach, it feels soft. The patient might not even be complaining of that much pain at first, and you think, phew, okay, they're good.
Why does that happen? If something's torn, shouldn't it hurt right away?
Not always. Blood itself isn't immediately irritating to the lining of the abdomen. It has a neutral pH. So it takes time for the inflammation to build up. Or the patient might be drunk or high, which dulls the pain.
Or they could have another injury that's just louder.
A distracting injury, exactly. A shattered femur that hurts so much they literally don't notice that their spleen is bleeding to death.
So one single check, one snapshot is basically worthless.
It can be dangerously misleading. That's why the standard of care is serial examinations. You don't check once. You check now. You check in 30 minutes. You check in an hour. You're looking for a trend. Is the belly getting a little tighter? Is the heart rate creeping up? A single data point is noise. The trend is the truth.
So we know the box is shaken. We know we can't trust a single exam. Let's talk about what's actually breaking in there. The source material splits the organs into two camps: solid organs and hollow viscous.
Yes, and this is the fundamental fork in the road for understanding what's happening. They behave completely differently when they get hit.
Let's start with the solid organs.
Okay, so think of the spleen, the liver, the kidneys. These are dense organs, they're heavy, and they are just packed with blood vessels. They're basically blood-filled sponges wrapped in a thin skin.
So when they get hit,
They crack, they fracture, just like a melon. And because their sponge is full of blood, they bleed a lot.
and the spleen is number one.
Number one, most commonly injured organ in blunt trauma, yeah.
Why is it so vulnerable?
It's just location and structure. It sits up in the upper left part of your abdomen, tucked right under your ribs. And if you break those ribs, the sharp ends can just puncture it. Or even just the force of a sudden stop, your body stops, the spleen keeps going, can tear it right off its blood supply.
And the liver is number two.
Yep, it's huge, it's on the right side, it's heavy, same thing. It has a lot of inertia. It can tear itself against the ligaments that hold it in place.
So solid organs means hemorrhage. That's the main threat.
Correct. They kill you by draining the tank.
Now what about the hollow viscous? Stomach, intestines, colon.
Think of these as pipes. They're not solid. They're muscular tubes. And they're carrying air, digestive juices, bacteria, waste. They don't bleed nearly as much.
But if a pipe bursts,
You get a leak. You get spillage. You're spilling acid and bacteria into the sterile abdominal cavity.
which sounds absolutely horrific.
It is. It causes a massive infection called peritonitis. But here's the key difference. Bleeding from a solid organ kills you fast. Minutes to hours. Infection from a leaking bowel that kills you slow. Hours to days.
Ah, so that explains why the shock signs usually point to the solid organs. They're the immediate threat.
Exactly. A patient with a small hole in their bowel might not look that sick for the first few hours. They're not in shock yet. But give it 12 hours and they'll be septic and dying.
This distinction, bleeding versus leaking, it seems to drive everything that comes next.
It does.
So we have our suspects. Now we need to prove it. This brings us to the tech. We live in this age of amazing machines. I'm assuming the answer is just put everyone in the CT scanner, get the full picture.
I wish it was that easy. But we go back to the tunnel of death. We have to make a hard binary choice based on one thing. the patient's stability. The source calls this the hemodynamic stability gate.
That ability dictates the tool.
It is the law. So let's take scenario A, the unstable patient.
Paint the picture.
Okay, this patient is crashing. Blood pressure is, say, 80/40. Heart rate is 130 and climbing. They're pale, sweaty, barely conscious. You're pouring fluids into them, but nothing's working.
They are actively dying.
Right in front of you. You cannot send this patient to the CT scanner. It takes too long to get them there, to get them on the table, to run the scan. You're away from all your equipment. You're away from the blood bank. You're away from the surgeon.
So the CT is out.
Yeah.
But you still need to know if the bleeding is in the belly. What do?
You use the FAST scan, F-A-S-T. It stands for Focused Assessment with Sonography in Trauma. It's an ultrasound.
Like when you're looking for a baby.
Same tech, totally different question. We bring the machine right to the bedside. The patient doesn't move. We put the probe on 4 specific spots on the belly, and we are not looking for details. We're not asking, is the spleen torn?
So what you looking for?
We're asking one simple yes or no question. Is there free fluid?
And free fluid is just a code word for blood.
In a trauma patient, yes. Fluid is blood until proven otherwise. We look at this one spot, Morrison's pouch. It's between the liver and the kidney. If there's blood, it pools there and shows up as a black stripe on the screen.
The black stripe, that's the signal.
That's it. You see that black stripe on an unstable patient, you have your answer. You don't need a detailed map. You know there's a massive bleed. You go straight to the operating room. Do not pass to the bed. Go. Do not collect $200.
So positive fast plus unstable patient equals surgery. It's that simple.
It saves lives because it saves time. Now, what about scenario B, the stable patient?
Okay, scenario B. Their blood pressure is normal. They're awake. They're talking to you. Their belly hurts, but they're not crashing.
Now we can all take a breath. Because they are stable, we can safely send them to the CT scanner. We do a contrast-enhanced CT.
Why the contrast? What does that do?
We inject an IV dye. That dye lights up all the blood vessels and the organs. It lets us see the difference between a healthy liver and a shattered one. It can even show us if the dye is actively leaking out of a blood vessel. We call that a blush.
A blush.
Yeah, it looks like this bright white puff of smoke on the scan where it shouldn't be. That means active bleeding.
So this is the detailed map.
This is the investigation of choice. It gives us the grade of the injury. Is it a tiny crack or is the whole thing pulverized? It gives us the information we need to plan our next move.
I love that logic. Technology serves physiology. You use the tool that matches the patient's ability to survive the test itself.
That's a huge takeaway. In medicine, in any field, really, just because you can run a complex analysis doesn't mean you should if the whole system is about to fall apart. Stabilize first.
So we've done our imaging. Let's say we have that stable patient. CT shows a moderate spleen injury. It's bleeding, but it seems contained. This brings us to what was, for me, the biggest surprise in all this research, the cut or wait dilemma.
Yeah, this is where trauma care has done a complete 180 in the last few decades, a total paradigm shift.
My assumption, and probably most people's assumption from TV, is that if an organ is bleeding inside you, you go to the OR, they cut you open, and they fix it.
And that used to be true. Blood in the belly meant a laparotomy, a huge incision stem to stern. But we learned a few things. We learned that, 1, the body's actually pretty good at healing itself, and 2, surgery is really dangerous.
More dangerous than a bleeding spleen.
It can be. Anesthesia has risks. Opening the abdomen releases all the pressure that might be helping to slow the bleeding down. We call that the tamponade effect. There's a huge risk of infection. And often, you'd get in there to try and fix a spleen, and it's so torn up, you just have to take the whole thing out.
And you want to keep the spleen if you can.
Desperately. It's a key part of your immune system. People without spleens are at a much higher risk for really nasty, overwhelming infections for the rest of their lives. So the modern approach is called conservative management.
Which sounds like doing nothing.
It's more like masterful inactivity. It's very active monitoring. We put them in the ICU. We check their blood counts every couple of hours. Strict bed rest. But we do not cut. We give the body's clotting system a chance to work.
You're betting on the body's own repair crew.
And for solid organs like the spleen and liver, it works most of the time, as long as the patient stays stable. If there's one specific vessel that's bleeding, we can even do something called angioembolization.
What was that?
Angioembolization, it's like plumbing from the inside. Instead of a big incision, a radiologist goes in through an artery in the wrist or the groin, threads a tiny wire all the way up to the bleeding vessel in the spleen.
Like a video game.
It is. And they use live x-rays to find that one little bleeder, and they plug it. with a tiny metal coil or some medical-grade glue.
Wow. So you stop the bleeding without the trauma-open surgery, and you save the organ.
It's elegant. It's really changed the game.
But there has to be a line. When do you say, okay, this isn't working, we need the scalpel? The source lists absolute criteria for surgery.
Yep. 3 main times we have to operate. Number 1, hemodynamic instability. If you're just pouring blood into them and it's coming out faster than you can replace it, you have to go in and physically turn off the tap. You can't wait. You need a clamp.
Okay, that makes sense. Number 2.
Peritonitis. If their belly goes from soft to hard and rigid, or their infection markers start spiking, that tells you something has leaked. Not just blood, but something dirty. You have to go in and wash it out.
Number 3 goes back to the pipes.
Hollow viscous injury. This is the big exception to the watch and wait rule. If you have a hole in your intestine, it will not heal itself. It's just going to keep leaking stool into your abdomen.
Yeah.
You have to go in and sew that up.
So to generalize, solid organs get a chance to heal. Hollow organs go straight to surgery.
That's a very good way to put it. A leaking pipe is an environmental disaster that the body just can't clean up on its own.
Which brings us perfectly to the next section. The silent killers. The outline calls a hollow viscous injury the final boss of diagnosis. Why is a hole in the bowel so much harder to spot than a bleeding spleen?
Because the signs are so subtle at first. Remember, solid organs bleed, they cause shock. Shock is loud. Hollow organs, they leak. And that initial leak might be tiny.
A slow leak.
Right. And here's the really scary part. CT scans can miss them. An early bowel injury, a small tear. It can be invisible on that first scan.
So the map can lie to you.
Or just be ambiguous, so we have to hunt for indirect clues. The biggest one is free air.
Air where it shouldn't be.
Exactly. The abdominal cavity is vacuum sealed. There should not be any gas outside of the intestines. If the CT shows little bubbles of air floating around, that air had to come from a hole in the gut.
That's the smoking gun.
It is. Another huge clue comes from the seatbelt sign.
I found this so interesting. The thing designed to save you is the thing that hurts you.
It's a trade-off, right? The seatbelt stops you from flying through the windshield. But in a high-speed crash, that belt pins your lower abdomen. The soft intestines get crushed between the belt and your hard spine.
And the pipe just bursts.
It can. Or it can tear the intestine right off its blood supply. So if I see that diagonal bruise across a patient's belly,
Alarm bells are ringing.
maximum volume. Even if that first CT looks normal, if I see a seatbelt sign, I am terrified of a bowel injury. I'm admitting that patient, and I'm checking their belly every hour, just waiting.
Vigilance.
Oh.
What about the spleen? We said it heals, but the notes mention something called delayed rupture.
Yeah, the hidden time bomb. Sometimes the spleen bleeds, but it bleeds inside its own capsule. It forms this massive, contained blood blister on the surface of the organ.
So the pressure is building, but it's contained.
Exactly. The patient feels okay, their vitals are stable, they might even go home, but that blister is under tension. And a week later, they cough, they sneeze, they strain a little too hard, and pop.
The dam breaks.
And they are in catastrophic hemorrhagic shock in their own living room.
That is absolutely terrifying. Does that happen often?
It's rare, less than 5% of cases, but it's why we give patients such strict instructions. No heavy lifting, no contact sports for months. You are walking around with a very fragile grenade inside you.
One last crap here is the pelvic and chest connection.
This is all about avoiding tunnel vision. The abdomen doesn't exist in a bubble. Its roof is the diaphragm, which it shares with the chest. Its floor is the pelvis.
The neighbors.
The neighbors. If you have broken lower ribs, those sharp bone fragments point inward. They can easily puncture the liver or the spleen. So a chest injury is an abdominal injury until you prove otherwise.
And the pelvis.
A shattered pelvis is a bloodbath. The pelvic bones are full of huge veins. If you crack that ring of bone, you can bleed liters of blood into the space behind the abdomen. And it's a space you can't really compress.
It's all connected. The closed box is just one room in a house that got hit by an earthquake.
That is a perfect analogy. You have to treat the whole patient, not just the part that's screaming the loudest.
We have covered so much ground. From the roadside to the ER, through the scanner, the decision to cut or wait, and all these little traps. Let's try to bring it all together. The source gives a 10-point rapid recap.
The 10 Commandments. Let's do it.
Okay, commandment number 1.
Context is king. RTAs are the top cause. Know the story of what happened before you even touch the patient.
Number 2.
ABCDE. Always. It is non-negotiable. Secure the airway and breathing before you even think about the belly.
Number 3.
Shock equals hemorrhage until proven otherwise. If they're crashing, assume they're bleeding. Don't blame it on pain or nerves.
Number 4.
The spleen is the most common injury, the fragile sponge on the left.
Number 5.
The unstable patient gets the fast scan, bedside ultrasound, yes or no on fluid, no tunnel of death.
Number 6.
The stable patient gets the CT scan, get the detailed roadmap, but only when it's safe to make the trip.
Number 7.
Solid organs are managed conservatively whenever you can. Save the spleen, let the body do its job.
Number 8.
Hollow organs, the leaking pipes, require surgery. They will not fix themselves.
Number 9.
Serial exams are vital. A soft belly is a snapshot, not the whole story. You need the movie, not just the photo.
And the final commandment, number 10.
Treat the patient, not the picture. Physiology always beats anatomy. A bad-looking scan on a stable patient can wait. A good-looking scan on a dying patient is meaningless.
It's such an elegant framework when you lay it all out like that. It takes this chaotic, bloody situation and it just turns it into a flowchart.
That's the whole goal, to remove the panic. When you're standing there, you don't want your brain to be going, oh my God, what do I do? You want it to be going, okay, what step am I on?
What step am I on? I love that. It just lowers the cognitive load so you can function.
Exactly. Chaos makes you stupid. Protocols make you smart. Stabilize first, investigate wisely, and operate only when you absolutely have to.
As we wrap this up, I keep coming back to that idea of the soft abdomen trap. It feels like a metaphor for so much more than just medicine.
Oh, yeah. How so?
Well, just in life,
Yeah.
in business, in relationships.
Mm-hmm.
How often do we just assume everything's fine because there's no obvious crisis on the surface?
Yeah.
Because the abdomen is soft.
That's really true. The surface can lie. A company can look fine on paper, but the culture underneath is just toxic. It's rotting. A relationship can look fine on the outside, but inside there's all this resentment building up.
So true insight, whether you're a trauma surgeon or just, a person, it requires looking deeper. It requires checking more than once. And it requires ignoring the loudest distraction to find the quiet thing that's the real threat.
And it requires knowing that stability is the prerequisite for clarity. You can't do a dupe analysis. You can't do the CT scan until you've secured the basics.
Absolutely. Secure your ABCs, then check the box. Thank you so much for walking us through this. It was incredible.
My pleasure. It's a fascinating and logical world.
And to you, listening, next time you see a soft surface, just remember, check twice. Watch the trend. Stay curious, stay safe, and we'll see you on the next deep dive.